I want you to understand that pain is not always related to mechanics or movement and or structure, actually, right? The way we generally think about pain is, hey, I have pain in my knee. Something structurally has gone wrong. And in a system that works really well, we should have pain in those scenarios. When something structurally goes wrong, assuming it's enough of a strong enough structural change where it's actually valuable for our brain to know that something is going wrong here, our brain should be telling us, hey, there's pain here. I need to adjust what I'm doing, how I'm moving in order to not create any more pain here. Now, no one I've ever worked with has ever moved perfectly symmetrical or what I would classify as move perfectly. And I believe the better way to manage pain is actually through the term that I'll use is fatigue management, but essentially managing volume and intensity to make sure that you can tolerate the stress we're putting on your body and then gradually increase that stress so that your body continues to adapt to it. So my first route of treatment or intervention would actually be, hey, let's just reduce the squatting, or let's start to pick some squat movements that we know are going to feel better on the knee. Let's bias a little bit more hamstring work. Let's bias a little bit more hip work. All of those things are going to make a more immediate impact. They're going to make you feel better, and likely they're going to build up some of the areas that probably need building up anyways in order for your knees to feel really good. What I'm looking for here in the squat is that there's relatively even distribution between the right leg and the left leg. So if we draw a line straight down the center here, as we get to the bottom, we should see that you keep this even balance of your pelvis or of your hip onto the right side and onto the left side. We shouldn't see this huge shift from one side to the other. General mechanics in the squat, this might be, more than you need to know, but what happens is as you initiate the squat, the hip is spinning externally in the socket as well as shifting slightly forward in the hip socket. That's the very initiation of the squat. So like right where we are here, that's the sort of mechanic that's moving. And keep in mind, there's never like a still mechanic. Like you're not in external rotation, you're moving into external rotation, right? You're not just stuck in external rotation or stuck in internal rotation. You're moving into external rotation and you're moving into internal rotation. So at the initiation of the squat, you're moving into external rotation and the femur is slightly more towards the front or anterior aspect of the hip. As you get lower towards like parallel, the femur actually then starts to rotate towards internal rotation and the hip moves into the backside of the socket. As you get to the very bottom below parallel, like in the very, very bottom, the hip actually starts to move back into external rotation in preparation to initiate the ascent. Those are normal mechanics that occur. Generally, where I see the most problems is around that parallel point because there's some sort of limitation in either the hip rotating internally or the hip shifting towards the backside of the socket. And like a tight posterior hip capsule that would be the fancy term for like the femur can't shift to the back because the capsule is limited. A tight posterior hip capsule is very common, secondary primarily just to like sitting and not exploring that space within the joint, and clearing up more range on that backside of the hip socket ends up freeing up a lot of motion in the hip, especially when it comes to some sort of rotational capacity. So, you can kind of think of it as like chicken or the egg scenario. Is my hip internal rotation limited because I can't rotate it, or is it limited because there's a posterior capsule or some sort of capsular restriction? Like why is the hip unable to internally rotate? Unsure exactly why that is or how it came about in the first place, but we know, hey, if we address the posterior hip capsule, if we address like active and controlled and coordinated internal rotation, we'll be able to get more freedom of movement at this parallel portion of the squat. So you're going to see here, let's again pay attention to this midline. You're going to see as you get closer to that mid point in the squat, that parallel point, you're going to start to shift towards the right. So I'll try to go slow. Okay, so even here already, there's a little shift of the pelvis towards the right. You can see that if I draw a line straight down from the knee here, so knee is kind of like straight down towards that first toe, and here it's more down towards that like second toe, right? It's like already there's a slight shift where this knee is having to bow out, this knee is coming in a little bit. And again, that's sort of like normal mechanic when you start to shift into one side. So I'll keep it playing. Okay, here. Doesn't look too bad. There's almost like a recorrection, but again, still, if I look at the knee and the ankle at this position, this knee is a little bit farther forward. I'm getting a little bit more ankle dorsiflexion. I'm getting less ankle dorsiflexion here, or the shin angle isn't quite as far forward. And then this next view should be like the most prevalent right about here. So right here is where you start to see that shift more drastic. Okay, so right here, this is a great image. So you can see I start to shift, my pelvis starts to shift more towards my right. This angle of the knee is closed more than this angle of the knee. You can see this is like a more open angle. This is a more closed angle. Same here, the ankle more closed, more open. Those are all signs that I'm shifting away from this side and shifting into this side. Okay, as you get to the very bottom and then the hip has to externally rotate again, nothing really changes. It's more that middle section of the squat. So let's see again here. Not bad, not bad. Everything is fine. Nothing here would worry me. But again, and I would love to go through that middle portion really slow. But you can see it right there again. Hopefully you can see it. Ready? You'll see this shift into the right. Everything shifts over this way just a little bit. And again, I'll see if I'll stop at this point again. You can see here, this angle is closed more. This angle is closed more. This angle is open. And this is a really good image, this stop here, because you can see that this shin angle is almost totally vertical relative to this one. This one, we have a little bit of travel of the knee farther forward, and we have almost none here. Again, shifting into that right side. So hopefully this gives you some idea as to what's happening. What I think there's a lot of things that could be going on. Again, when we talk about the mechanics, if I have a limited hip internal rotation here at this midpoint, I'm going to shift away from that side. Or if I have a limited posterior hip capsule, like I don't have good mobility in the hip capsule, I'm going to shift away from that side to the other side. It could also be because my knee can't travel farther forward. Because I have a foot or ankle limitation, I have to shift away from that side. Now, looking at your hip rotation, you do have more limitation on your left hip internal rotation and harder time controlling or coordinating the left side. You'll see if you go back and watch the hip internal rotation video, you get this, like, you try to use your foot as the primary mover of that hip internal rotation, more so on the left side than the right side. And when you look at your right side, it's like a little bit smoother. Like you could tell there's not as much effort to rotate it relative to the left side. It takes much more effort. So there is a limitation in the left hip internal rotation, which again could be causing this shift. There was also a limitation in hip external rotation on the right side. I'm less worried about that, but it's something to like just always pay attention to, right? If we're aware of this and we can improve it, great. And that's also a very normal pairing. Normally, when someone has a limitation in hip internal rotation on one side, they have a limitation in hip external rotation on the other side. It's basically a compensation for how you're distributing weight from leg to leg when you're standing or when you're walking. And there's all these mechanics that change the pelvis. Not worth going into, but at another time where I can send you a video of like a couple different videos that explain that concept. But the other thing you said about the foot is you sometimes feel more pressure on the outside of the left foot. Why that may be is because you can't properly pronate on the left foot. Pronation is when your ankle is collapsing, and the mechanic of pronation occurs with dorsiflexion. So when I go into a squat and I'm trying to get my knee to go forward over my toes, there should be some natural collapsing of the foot, and the weight should distribute from sort of the outside of the foot towards the first toe during that mechanic. So during dorsiflexion, during pronation, my weight should distribute from the outside of the foot towards the big toe. If I don't have proper pronation or I don't have proper ankle dorsiflexion, and again, those two are kind of one and the same because they occur together, then I have to work around that. I have to put my weight on the outside, or my weight stays stuck on the outside, and I can't get this normal ankle dorsiflexion that I want to see, like I am seeing on this side. Looking at your squat and then looking at your hip rotation and seeing just how your ankle and foot is moving in this video, I would lean into saying that this is more of an ankle issue than a hip issue. Both can likely make change, but I think this is the bigger problem. The foot and ankle on the left side, I think, is a bigger contributor to this squat mechanic than the hip. That being said, you can change a hip far quicker than you can change an ankle just because of the type of tissue that surrounds that joint. The ankle is very like hard, ligamentous tissue, and so it's harder to make change, whereas there's a lot of like contractile tissue, muscle tissue around the hip joint that you can change much quicker than the ankle. So I think it's valuable to work on both of these. But I think like when we see true change to the foot and ankle, we'll probably see more true change to this squat mechanic. Okay, hopefully this was helpful. Hopefully not too overwhelming. Let me know your thoughts.